buying in and so forth. So that's extremely important. Some websites out there. The Charlie Foundation is very big and very helpful. Carson Harris Foundation books. There's a Ketogenic Diet 5th edition, the Keto Cookbook, and that sort of thing. And then obviously there is a website, Atkins4Seizures.com, that's very specific on the modified Atkins diet. The South Beach book is helpful in finding heart healthier, high protein, higher fat items. Using a lot more olive oil and monounsaturated fats can still have a heart protective effect. The best book I've seen in the lay literature is the Glycemic Revolution book. It's actually written by a gentleman for the lay population who's had quite a few scientific published papers. So that's a very good book. It has a very good index for glycemic foods. So in conclusion, there's several mechanisms that work. The one slide that I showed you there with all the hormones and pathways and that sort of thing really is a theoretical model. We thought ketones were the key, and now we understand with low glycemic index that it might be a more complex model that works for different people. It is important to know that the recent studies and the newer literature is showing that more liberalized diets are possible. And so I've talked to families that said we would never try the ketogenic diet. We just couldn't make that work for our family and so forth. And these newer models out there are very promising in allowing a diet that that the child can be a child and the family can be a family and so forth. It's important to work with your team to try to find where your limits are and where you are at. We think and we hope to study this, that we might be able to, with a combined modified Atkins and low glycemic index, get patients over that 30-gram model and still have good results. So there's that. What would a sample menu look like? Sausage and eggs for breakfast, a tablespoon of butter, coffee, a tablespoon of cream, and so forth. So for all of us parents who are struggling with weight, isn't that our diet already? So 8 ounces of grilled chicken with salsa, cheddar cheese, broccoli, olive oil, and an unsweet tea. Dinner is a 6-ounce steak with a 1/3 cup of green peppers, cooked in olive oil. Again, you're seeing that we're adding those heart-healthy fats in. Cup of spinach leaves with 2 tablespoons of red vinaigrette. I like that with a little sauteing that in a pan with a little garlic. That's awesome. Serve that at one of our meals here one day. So there's a sample menu. There's a couple of other days in there, but you guys get the point, and I'm glad to be here with you today.
Very nice, Ron. I don't know how many people are still hungry out there, but there's still a lot of food out here. We're going to move on to the scientific program. I actually had Danielle ask me if I could kind of tie it all together in the transitions from childhood to adult epilepsy, which is my specialty, and look at some of the future directions that we have in the treatment of epilepsy. And it's actually a very good time to have epilepsy because we have so many emerging treatments that it becomes very exciting to talk about. So the first thing is, in speaking about rare diseases, I have probably the most mysterious disease that at this point is being investigated by the CDC. It's called the nodding syndrome. Nobody's ever heard of it, I'm quite sure, because I just learned of it very recently. But it is a progressive encephalopathy that's seen in East Africa, in the Sudan, in Tanzania, and it affects kids that are transitioning into adulthood between 5 and 15 years of age. And it's a devastating disease that's really not very treatable at all with antiepileptic drugs. So it's very pertinent to our discussion today. In this case, we can see both the generalized seizures that you heard about from Dr. Abrams and Dr. Sheff this morning, and also focal seizures. And while I don't have a video of somebody from Eastern Africa in the Sudan, what I do have is I have a video of somebody that has what I think is its counterpart here in the United States. This is an individual with frontal lobe epilepsy. It oftentimes is very much mimicking this nodding syndrome that's been described by the CDC.
Arm is slightly stiff in an extension
Very
posture.
subtle movements when we examine him in the epilepsy monitoring
Point to the
unit.
ceiling.
He's still able to follow commands. This was a 16-year-old boy that ultimately underwent a left frontal cortical resection and has been made seizure-free from these focal seizures. He did not have the nodding syndrome, but this is what it would look like. And I wanted to give a plug for the upcoming advocacy that is going to be held in the Capitol over the next week. If you go to the website and look at rare diseases, you will find out more information, probably about this one as well. So these are the faces of people that have epilepsy, and if I ask you to pick out the one that has epilepsy, you'd point at any one of them and you'd be correct, because these are all people that do have epilepsy. And they have many, many different faces. Some of them are rambunctious and younger in their teenage years. Some of them are sick, and some of them are companioning with their daughter that have epilepsy, and some of them companion with animals that also have epilepsy, not the dog, but the patient. Pregnancy, those with special needs, and even those famous people that are advisors for President Obama are not removed from the possibility of developing epilepsy. And I like to think of it as somewhat of a tip of the iceberg type of syndrome, because while we're looking out over the crowd, and some of you may have epilepsy, we could certainly never know that until you have the seizure. And at that point in time, we're drawn to a dramatic clinical manifestation of what is only part of the underlying individual's life. So as you heard this morning quite eloquently, there are many different facets, many different components, all that need to be addressed when somebody's first diagnosed with epilepsy. And you heard much about the consequences. This was actually from survey information that was taken from a large group of people with epilepsy. There is, in a 19-state review, a very huge epidemiologic study, the consequences of epilepsy itself, and we found that there were both mental and physical health-related quality of life issues, and frequently that's what we hope to capitalize on, not so much the elimination of seizures, because as you heard this morning, we can't always do that for everybody, regardless of our desires to do that. But what we do try to do is optimize the health-related quality of life. We are finding that those individuals that do have epilepsy are also prone towards other conditions, such as diabetes, or being overweight, or stroke, and especially depression. Depression in those that are uncontrolled can mount up to about 50%. It's huge. And so these comorbidities also require another layer of treatment that's seen beyond just seizure control. You heard a very nice presentation by Dr. Cox earlier on memory and cognitive impairment. We see that as a triple-layered problem, not only one from seizures, but what causes the seizures from a brain perspective, and also the effects of the antiepileptic drugs or their combinations that we choose. Injury, unemployment, household, lifetime income, healthcare overutilization, it all happens. I didn't mention the one thing that's perhaps the most devastating, which is fatality. And one of the people that I showed you actually passed away from their epilepsy, one of my favorite patients. And so this breeds the consequences of what patients complain of. They're very much fearful as to what will happen to them down the road. When will the next seizure come to pass? Will it be in an area where people will understand, or will it be where they're by themselves? There are life limits that are set, and a great stigma that occurs for some of the people that live with this condition. And many of them will suffer from antiepileptic drug problems, and that's something that we can do something about. We can try to improve seizure control, and I'm going to show you some advances that might help with that. we can also improve our anti-epileptic drug choices. And this is where we actually now have many new options that might become available to make that happen so that the problems are less. But one of the first things that we see is doing what we're doing today, is we're trying to improve awareness through Project Access, through conferences that are educational throughout the country, so that if we talk about it, then we can become more comfortable with exactly what's going on. The myths that we see are promulgated even now, and patients are referred to as epileptic, not as much. A seizure disorder is not the same as epilepsy to many, though we use these terms very much interchangeably. Patients with epilepsy are not necessarily intellectually challenged, though they may be. They're not mentally ill, even though there may be psychological problems that can arise from epilepsy. Most epilepsy, in fact, is not inherited. However, as I'll show you in a bit, the tides are turning, and we're learning much more about genetics. Epilepsy is not contagious, a very important point to make, and treatment is not necessarily lifelong. But as I'm trying to illustrate down here, epilepsy is something that comes from the brain, and so it's really just a symptom. This was taken from a patient of mine, and I think I saw her earlier, a very beautiful artist rendering. She's talented. I'm not, so I'm going to show you her picture instead of mine. But essentially, if you look at this picture that was designed before she was rendered seizure-free, what you would see the EEG mixed with love, mixed with a lot of spiraling down and tears, a very telling composite of what the emotions are that people feel inside their bodies when they actually are troubled by this condition. And it's almost as though you're trying to get your target, but it's just beyond your reach. It's just out of reach. So what can we do? And what we can do is initially improve our diagnosis. The sooner we can diagnose, the sooner we can effectively treat for the conditions that somebody suffers from. But as I said, and as Dr. Abram pointed out, the seizures are only a symptom of an underlying brain condition, and the symptoms that you experience are a reflection of where the seizures began. If it involves the language center, you may not be able to speak, or may have problems speaking immediately after the seizure is over. If it involves the visual cortex, or the visual part of the brain, you may have problems with your eye movements, or you may go blind during the time period where the seizure is affecting you. 2 or more means that you have epilepsy. An epilepsy syndrome is what we refer to as a constellation of symptoms that occur at a specific point in time with a specific group of symptoms that require a certain treatment over the course of a lifetime. Juvenile myoclonic epilepsy, Dr. Sheff mentioned earlier, that's probably one of the most common syndromes that we see. And for what we can do now is relative to the newer trends that we see, we're finding that the brain works based on different channels in the brain that use various types of what we call ions. They're chemicals that allow one brain cell to talk to another. And we're finding that with epilepsy, there's a host of these different channels that are disturbed. That's been found and proven by some of the genetic studies that we have now. We're finding that chromosomal abnormalities, such as I'm showing you here, relative to brain development, are now being identified with greater frequency. And the idea is that if we can identify them early on, perhaps even before the individual is born, perhaps we can provide information to the parents, perhaps we can at some point in the future modify them to create a better outcome. What I'm showing you is a disordered brain over here on the right and a large fluid-filled area here in the center that is abnormal. We're finding that some of the epilepsies are actually antibody-driven. That is, that the body is preparing proteins that attack its own cells. It's a phenomenon known as autoimmune epilepsy, and if you've ever heard of conditions called lupus or thyroiditis, these are common systemic illnesses that may actually have autoimmunity and become associated with epilepsy. This is kind of our biomarker when we look at trying to diagnose. The EEG, the electroencephalogram, was actually devised in the early 1920s, and it was actually a neuropsychiatrist who had a son that was the first one to have the human EEG. This was back in 1929. But if I show you some different examples, this is an isolated spike, which is in one part of the brain in somebody with focal seizures. This is an example of somebody with a generalized distribution to their abnormality that has generalized seizures. In this case, they're more localized to the occipital region. In this case, this is somebody that has a continual seizure that's occurring on prolonged monitoring that we're frequently using now when patients are admitted with various types of neurological conditions. And this is a seizure itself on the EEG. And when I saw this EEG, when I looked back at the patient, there were no signs at all that could be identified. This was actually taken from our monitoring unit where it was an older gentleman whose wife was 3 feet away from him. And he had the seizure on the EEG. They were watching TV. They never ever knew that it ever happened. So monitoring units have sprung up all over the country. And the reason is because now we can look at behavior and we can link it up with the electrical properties of the brain to prove, without wishy-washiness that we sometimes have to use in the clinic, we can prove that somebody has epilepsy or not. We can help classify how that epileptic seizure occurs, whether it's in one part of the brain, whether it's throughout the brain. We can characterize the seizures when we see them as to where they begin in the brain, to see if there's actually one spot that might be amenable for surgical resection. So what you see here is a microphone to listen to the audio input. The video cameras are over here looking down. This is all the vital signs and vital net information and the blood pressure cuff right here. You can see the electrodes on the head, the very nice wife that's standing by supporting him. That's what a monitoring unit looks like, and I know many of you know from experience. But what's now on the horizon are direct recordings from the brain, and for years this has been done. It's been done for perhaps 100 years now, initially pioneered in Canada and coming to the US about 50 or 60 years ago. And it seems that when we record from the brain that we find out direct information about the ability of the brain to generate these potentials that are associated with epilepsy. By putting the electrodes on the brain that I'm showing you over here, it's debatable if they're not having seizures as to whether it's effective or not. Most people think it's probably not. But there's areas of increasing interest. We're now being able to map function in the brain and determine exactly whether there's a critical area involved near the seizures or not. We're able to use this electrical monitoring to try to interrupt various nerve tracts that may prevent spread, if not removal. We can help identify functional areas that are important for our strength and our movement. And there's a very exciting development and interest in prosthetics that are being used based on the electrical power of the brain. So individuals that have prosthetic limbs perhaps from a spinal cord injury or from a brain injury and a stroke, can now use their brain to actually move an artificial limb. And some of the work that's being done by my colleague, Dr. Shi, is actually looking at visual prosthetics to see if we can't help those that are not sighted or those that are weak perhaps regain some of the function, all through the power of the brain converting its electrical activity to mechanics. And so this is the latest in terms of what we hope to seeing in the future, which is a brain net composed of a recording device that's actually able to synthesize the electrical activity and translate it into functions that may or may not have been lost. And in this way, we're now using here various types of co-registration to see the electrodes, see the brain, to more precisely pinpoint where the abnormalities are. But we're going beyond that, and we're now looking at very, very fast frequencies that have never been looked at before. These are frequencies that are so fast that they're missed on the EEGs and haven't been recorded for nearly 100 years. These are frequencies that have been buried and missed relative to the normal brain waves that you see here. The faster frequencies that you see here are known as high-frequency oscillations. And these are the areas that actually may be connected to the electrical properties of epileptogenesis itself. So we're learning more about what's been in front of our face for years, now being able to identify areas of electrical abnormality that actually may be the underpinning of where seizures begin in the brain through these high-frequency oscillations, these atypical frequencies. And what I'm showing you down here is that there are things that have been referred to as micro-seizures, which are seizures that are localized to just single columns of cells that are being recorded in research tools to help identify precisely the abnormal tissue that's involved in the generation of these seizures. And it's very, very interesting because we're seeing some of these micro-seizures in people that don't even have epilepsy. And the idea is that, as you heard earlier from Dr. Sheth, that there's a threshold, like we've known all along, and that there's a network that, with the proper connections, are being allowed to manifest these electrical properties that exist in all of our brains. So it's kind of exciting and really the latest of all research. Here's an example of the electrodes in somebody that's been implanted for intractable epilepsy, and fortunately now is seizure-free. But that's what it looks like on a skull X-ray. So Dr. Abrams showed you this earlier. This is our bag of tricks right now. We have anti-epileptic drugs, or probably better referred to as anti-seizure drugs, since they don't prevent epilepsy. Our goals for treatment are no seizures and no side effects for anybody that has seizures. And when it doesn't seem to work out that way, then epilepsy surgery, or various types of neurostimulation that I'll talk to you about in a bit, are potential options for these individuals. You heard from Ron Stone about ketogenic diet and the potential benefits, and we're very excited to have Ron and Leanne here at Mayo to help pioneer some of these works that are so important for the patients. But I want to show you some examples because video monitoring has become so important in terms of helping to classify and select out individuals that are not controlled with medicine, for which we said about a third were, for further interventions when drugs don't work. Here's an example. This is a little baby that is in the newborn nursery, and if I can point out on this side, there's twitching of the left arm and the left leg. Looks pretty subtle to me, but to a pediatric epileptologist or neurologist, they'll pick up on that right away as a focal seizure. And as you saw from Dr. Sheth's fine talk earlier, most of the focal seizures in most of the seizures in the newborn are indeed focal. Now, if we go into what happens to these individuals later on in life, they frequently develop these mixed seizure types. That's an individual with a generalized tonic seizure. You heard it mentioned earlier, the Lennox-Gastaut syndrome, but frequently what happens in the early developing brain is delayed and manifest in different ways in the adult. So by the time we see them in the adult epilepsy clinic, they're frequently mentally retarded with abnormal EEGs with multiple different seizure types, of which this generalized tonic seizure is one of the most common. Now, I don't think that's going to work. Well, I have to tell you about this one. This was actually a very interesting case in the sense that this was a 15-year-old whose family did not believe that she had epilepsy, who had a series of myoclonic jerks that started when she was 12, ultimately culminating into 2 generalized tonic-clonic seizures over 3 months. And the family was in great denial, and even after video monitoring, was unaccepting of the diagnosis and or the treatment. Fortunately, the mom, who was, I think, the more rational of the two, was able to surface and convince the individual to pursue treatment, which was then successful, as most of them are. Oh, that's not going to work either. So I'm going to have to tell you about this one. And this was actually an individual that had 2 different seizure types. The one I was going to show you was actually a psychological reaction that we see in adults and that they don't see in pediatrics. But psychogenic non-epileptic attacks are very, very common in the adult population, to the tune of perhaps 20 to 30% of people that are diagnosed and treated for epilepsy actually come into the epilepsy monitoring unit only to have spells that are not epilepsy at all. So we frequently will re-diagnose these individuals, and it's probably a condition that's more common than you think. It's more common than multiple sclerosis. It's more common than cerebral palsy. It's more common than Lou Gehrig disease. And it's more common than trigeminal neuralgia or tic de la rue, these psychogenic non-epileptic attacks. The video monitoring is a huge advance in the treatment of epilepsy because it gets rid of those that don't have epilepsy. So what do we have and how good are they? Well, you heard efficacy this morning, and what we really hope to focus on now at this point in time is effectiveness. Effectiveness is a term that takes on seizure reduction and the efficacy, but also the tolerability and how many side effects an individual has to incur to be able to take their medication, because as C. Everett Koop said, our former Surgeon General, if patients don't take their drugs, they won't work. And there you go. But if we look at drugs in general, what you'll see is that about 63%, you heard that number earlier, about 2/3 are seizure-free when they have focal seizures. If they have generalized seizures, it's probably a little bit better. If they have to undergo surgery, they want to have mesial temporal lobe epilepsy because that's got a very high seizure-free rate. In green is seizure freedom. So if there's a spot on the brain, we find that to be a very good, probably a surgically remediable syndrome. When there's no lesion or no spot, then the numbers start to go down. Hemispherectomy is a very rare type of surgery. It's usually done in children with infantile hemiplegia. It's a very effective surgery, but it's a very drastic surgery, and we don't see too many of them. It's the children that usually undergo these procedures. And the split brain procedure is usually a disconnection surgery and not expected to lead to a substantial seizure-free reduction, or seizure-free outcome, rather. In the red, you see the various forms of neurostimulation. We have the vagus nerve stimulator approved in the United States and in Europe. In Europe, they've approved the anterior thalamus neurostimulation. It is not approved here in the United States, nor is the responsive neurostimulator, which is like a defibrillator for the brain. I have an example I'll show you. But it's pending approval, so you might hear about it in the upcoming months or even years. But one of the things that we fight with every day in the clinic, and I'm sure that anybody that touches the lives of individuals with epilepsy wants to know, what about generic drugs? And I don't know that this is an advance. I think it is for cost savings. But I don't know that it's really an advance relative to treating somebody with seizures. And while it's true generics has saved us billions of dollars, it may be that for patients with epilepsy that we're a select sort of group, that perhaps we can't afford that small area, that therapeutic window that might be different between the generic drug and the brand drug. And in fact, even though the evidence is somewhat limited, there are reports of patients that have had breakthrough seizures due to generics that have had loss of their epilepsy control, which is even worse due to generics. And in fact, there was actually a very recent study from the Johns Hopkins University looking at the pooled studies of all the generic drugs that came through the FDA. And what they found was that it's different. It's different in terms of the way it works in the body. And they found rather small areas of difference, perhaps greater than 15% for some of the critical pharmacokinetics that go into the way of how a drug works in the body. But we don't know that someone can tolerate 1% or 0.5%. So there's more of a fudge factor with generics. Now, what we usually recommend is that if somebody has to have generics because they're very, very expensive, and if they have to have generics, the one thing that we can do is recommend the same generic drug each and every time they refill the prescription, because it's the indiscriminate switching that seems to be the biggest formula for potential failure. Here's a story. Call your attention to these 4 pill bottles right here. There was a 38-year-old Haitian lady that I was taking care of who was drug resistant to everything in the book. As luck would have it, she was admitted, and somebody in the ER gave her Dilantin, which she always said I'm highly allergic to, by accident, and she became seizure-free. Go figure. Anyway, she presented to the emergency department again with a bag of pills, and this was within the bag, with her medicine, and she kept saying, these are not my pills. These are not my pills. They make me dizzy, and I don't like the way they make me feel. Well, each month, she'd been back to the pharmacist, and in this case, 1 month had red pills and white pills. In this case, white pills. In this case, gray and white pills. And in this month, gray and white pills with a pledgelet and white pills on top. This is the same drug. It's all generic phenytoin. And she wasn't handling it well and was very confused because while it was fortunate she was controlled on one drug, they clearly looked different. So side effects. Side effects are something we can do something about because when we look at side effects, there's 3 different layers. There's those that are the acute side effects. We see neurological problems. We see symptomatic problems from a systemic effect, nausea, sleepiness, dizziness, double vision, can't walk, the more cognitive and psychiatric problems that can occur. On the chronic basis, most become very focused in terms of the patients that look at what those drug side effects cause. And they'll hear about the cosmetic effects of gingival hyperplasia from what drug? Connective tissue abnormalities, endocrine problems, nerve injury, thinning of the bones, as you heard from Dr. Sheth, and weight gain, especially with drugs like valproate or Depakote, gabapentin and Neurontin, pregabalin or Lyrica, carbamazepine and Tegretol, or oxcarbazepine and trileptal causing weight gain. But what the doctors really worry about, or I think should worry about, are those that are the idiosyncratic side effects, because those are the ones that can kill. These are the ones that have an unpredictable response. We can't guess who's going to be the one that's going to have a problem, whether they're going to be the one with rash, or whether they're going to get a lupus-like autoimmune syndrome, or whether they'll have failure of acute organs such as the pancreas or the liver. And it can happen all from being drug-induced. And overall, there's probably 100,000 deaths each year due to medication-induced adverse drug reaction, and that's a fact. About 80% of people or so, depending on the study that you read, will complain of at least one side effect from their medication. And the focus has become on some of the newer drugs that in a comparison analysis seem to be better tolerated. Not for everybody, but for groups of individuals. So some of the newer drugs have a favorable ability about the way they work and also the way they're tolerated. I love this slide because it's so true. In each partnership, patient, physician, it requires open dialogue and open communication. So the doctor's saying, how am I supposed to know you're allergic to these unless you tell me? Well, he should know what kind of allergic reactions to potentially talk to somebody about so that an individual can see these findings if they occur. And the reverse is, if they're seen, then they need to be reported to the doctor so that changes can be made. So it's kind of a two-way street, really. So pregnancy and birth defects have huge strides that have been made. We know a lot more now than we knew 10 years ago. And even though the FDA is not allowing us to study pregnant women, the world has banded together and said, we need to find out what the effects of these medications are, and there are now worldwide registries about what some of the side effects of the medication are on an unborn baby. We know that there's seizure risks that can occur during pregnancy. There may be about a quarter that increase in frequency. Most don't, and some get better. Prematurity, miscarriage, intraventricular hemorrhage, rarely it's a passed on trait. I think that's over dramatized a lot of the time. So while the seizure risk is real, it's probably not that bad. What is bad is the effects of the medications, and it's all about the drug. It's not about having the epilepsy, it's about the drug that you take for the epilepsy. And in the developing child, up until about 4 weeks of age, that's the warning time. That's where everything's changing, where things are developing. And within the first 3 months, where the development of the internal organs is taking place, this is a critical time period for drug exposure. And we know that malformations are increased, probably about double, to the tune of about 4 to 8%. The more drugs you take, the worse it is. The higher doses you take, the worse it is. It's almost like common sense here, isn't it? And there are certain drugs that should be avoided. Depakote is a drug to avoid in women that might become pregnant. And in the United States, guess what the age range of a woman of childbearing potential is? Good guess. It's actually 9. I think of 18, but it's 9 to 51. So any woman that comes in and is 9 to 51, even if they say, I'm not sexually active, because we know things can change overnight, we have to use extra caution for them and assume that they may be one of the 40% of women that get unexpectedly pregnant. And so if they're exposed to drugs like Depakote or exposed to drugs like phenobarbital, those are the drugs that are the highest risk drugs that women can take. And this has actually been found in multiple studies across the globe. Other risk factors that are new risk factors, lamotrigine or lamictal, topiramate, and topamax have been associated now with cleft palate